So, this is my knockout. Am I Muhammad Ali, which is bariatric medicine? Or am I the other guy? And how do we move forward? Forward. Come on, Muhammad. Can use this. Yeah? Yeah, that's fine. Okay, so these are my disclosures. And I begin here. I believe the core problem with type 2 diabetes is this. And in fact, Elliot Jocelyn in 1927 stated, from an excess of fat, to move it forward, no, just fine. I can move forward. I just want to move forward, that's fine. From an excess of fat, diabetes begins, and from an excess of fat, diabetic patients die. So we have to deal with this excess fat. How can we deal with it? Well, we know for many years, bariatric surgery, whether it's sleeve gastrectomy, whether it's to a lesser extent, I think, using the pouch, and of course, bypass, is effective in reducing weight and also improving outcomes in terms of diabetes. How does it achieve this? Well, if you look at the SOS study, it's not magic. There is a restriction in terms of the amount of energy that goes in people with bariatric surgery. So it's markedly reduced from 2,500 down to 1,500 kilocalories compared to the control. And actually, when people lose weight, they also become more active. So activity increases in people with surgery. But a key thing to look at here, actually, to take away from here, is that actually, in the surgery group, you can see there's a drop, but then over time, 10 years, there is an increase in the energy intake. There is also, you can see, a drop in the amount of physical activity we do. So when you look at these people, in the bariatric surgery studies, there are two things to note. One is that the average weight was very high, 120 kilograms. BMIs of 41. And what did they achieve? Well, if you looked at the control group, not very much. But you can see banding. There is a weight reduction of about 20%, vertical banded gastroplasty, 25%, and the best outcome is with a gastric bypass, about 35%. So that's the numbers you're talking about. Excess weight from a starting weight of 120 kilograms, you're losing 20, 25, maybe 35%. But then over time, what you see is there is a steady increase in weight, even in people who've undergone bariatric surgery. And so, it's no surprise that when you use a cutoff, actually of A1C of 6% as a cutoff for remission from diabetes, not 6.5%, 6%. Now, would you say that 6% is an appropriate cutoff for saying somebody does or doesn't have diabetes, remission from diabetes? I don't think so. I think 5.7% should be the cutoff that we should be using. So they kind of cheated a little bit in the SOS study. And what did they show? Well, at 2 years, what they showed is that 72% of people who had diabetes had a HbA1c less than 6%. So 72% of people had been cured of their diabetes. But at 10 years, this had gone down to 36%. Why was that? Well, because people had regained the weight. And similar story for the blood pressure as well. So we know that bariatric surgery works. It's effective in the first 2 years, but at 10 years, you've actually half of the people have got the benefit. Why? Because at 2 years, 23.4% had. So then we compare, this is in the early phases actually, where trials have been done. This is actually Shower published this in New England Journal of Medicine 2017. Okay, where they compared medical therapy with sleeve gastrectomy with gastric bypass. And what you see here is change in BMI, clearly medical therapy not really that effective at that time. These are studies done 2012, 2013. You can see the weight, major weight loss is clearly in the bariatric surgery group. And of course, glycated hemoglobin is lower in the people who've undergone bariatric surgery as opposed to medical therapy. And if you look over time, what you see is in the medical therapy group, that the first two blocks, not very much changes. But in the sleeve gastrectomy and gastric bypass, you can see that you get really changes in terms of the number of medications people are taking. In fact, HbA1c less than 6% is achieved in 5% of people in the medical therapy group. So not very many people go from diabetes to becoming apparently non-diabetic. But you can see in the gastric bypass group, 29%, in the sleeve gastrectomy, 23%. So greater weight loss, lower HbA1c, more people have gone into remission. But that's because the medical therapy doesn't do well. Why? Because at the time when these studies were being done, very ineffective therapies. On the whole, if you look, Orlistat achieves maybe a 3% weight loss, or 3 kilograms. Phentermine, 3 to 5%. Bupropion, naltrexone, 3 to 5%. Topiramate, a little bit better, maybe 5 to 7%. So really, relatively ineffective therapies. But now I think that's changed. And I put up this quote from the opening lines of Charles Dickens, A Tale of Two Cities. It was the best of times, it was the worst of times, it was the age of wisdom, it was the age of foolishness. And I really believe now we are in the best of times in terms of diabetes management. And I put up this plot of the therapies that have been used for diabetes. And this has changed completely. So if you look in the early days of diabetes management, we had insulin, of course, developed for type 1 diabetes, but used a lot for type 2 diabetes. You have sulfonylureas, biguanides, and you have a few other therapies. But what's common about insulin, about sulfonylureas, about thiazolidinediones? What do they do to the patient's weight? It goes up, doesn't come down. Okay? So, but that has now changed. In the last 10, 15 years, we have witnessed a change in the types of medications that have been developed. So DPP-4 inhibitors, weight neutral. SGLT2 inhibitors, you lose some weight. You don't gain weight. And of course, we now have the GLP-1 therapies where for sure we are losing weight. And then we have GLP-GIP, and we have now got the triple agonists as well. And I'll go through that data. So, today, in 2023, is it bariatric medicine or is it bariatric surgery? Well, actually, some of the lessons that we've learned probably are from bariatric surgery. So when bariatric surgery works really well, how do people lose weight? Well, they reduce their energy intake, there are changes in the vagal tone, but a key feature of bariatric surgery is that GLP-1 levels go up almost 20-fold after bariatric surgery. So this is metabolically something extra is happening in bariatric surgery that we could be using for bariatric medicine. So we have what I consider now is the incretin revolution. And that is starting from finding something that couldn't be broken down by DPP-4 in the lizard to something like this, which is essentially 1993, Michael Nauk shows that native GLP-1, if you inject it IV or subcutaneously, you can have an impact in terms of glucose lowering. We then get short-acting GLP-1 RAs. In 2003, Feynman shows that you can give a short-acting like exenatide, and this can potentially improve glucose. We then have long-acting GLP-1 RAs, and we have the oral peptide GLP-1 RAs. So GLP-1 approvals, you can see from 2005, exenatide short-acting to the most recent, which is semaglutide long-acting, once-weekly GLP-1 agonist in 2019. Now, do any of these medications have benefits? Are they the drugs that could be providing us physicians with an ability to provide bariatric medicine? I believe we do, and this is the data. In the New England Journal of Medicine, John Wilding published this in 2021, once weekly semaglutide in people who are overweight with obesity and pre-diabetic, some of them. What you see here is a body mass index, though, a weight. Look at the weight. This is 105 kilograms. This is not 120 kilograms where, on average, where bariatric surgery was undertaken. 100 kilograms. Glycated hemoglobin, you can see, was 5.7. But a proportion of people had pre-diabetes, around 40% already had pre-diabetes. So what happened to them? Well, they lost weight. On semaglutide, you can see they lost about 14 kilograms in weight, change, because their average starting weight was about 100. And more importantly, about 32% actually lost more than 20 kilograms, 20%. So we now have an effective therapy for weight loss. More importantly, you look at the HbA1c. It reduced, even with the starting HbA1c of 5.7, reduced by 0.34. And in fact, what I would use as the operative definition of remission from diabetes, which is less than 5.7%, was achieved in 84% of people on semaglutide compared to 47% of people on placebo. We then have oral semaglutide. Well, if you look at oral semaglutide, whether you compare it to placebo, and this is the body weight reduction, you can see you get about 3 kilogram weight loss. DPP-4 inhibitors, again, 3 kilograms. So on the whole, with oral semaglutide, 14 milligrams, which is the maximum, you're going to lose 3 to 5 kilograms of weight. Okay? It actually even does better than dulaglutide once weekly, subcutaneously, and liraglutide. It also, beyond weight, is actually now being shown to have an impact on fatty liver. So this is a Japanese study, 16 subjects with type 2 diabetes, non-alcoholic fatty, or we call it MAFLD now. But look at the weight, 74 kilograms. Okay, so these aren't people who are grossly overweight, but they've got fatty liver. HbA1c is good control. They were given oral semaglutide, 14 milligrams over 24 weeks. What did they find? Well, body weight reduced, as you'd expect. HOMA-IR improved. HbA1c improved. But look at the markers of fatty liver. AST improved significantly. ALT improved significantly. Gamma-GT improved significantly over 24 weeks. Moreover, there was a relationship between body weight and fatty liver, but there was an improvement in FIB4, an improvement in ferritin, and an improvement in type 4 collagen, markers of fibrosis. So fatty liver and fibrosis within 24 weeks, 14 milligrams of semaglutide improves this. But we now have beyond 14 milligrams. So this is the OASIS study published in the Lancet, 50 milligrams of oral semaglutide. Because as you know, oral semaglutide, the bioavailability is very low. 1% of the drug actually gets into the circulation. So this is higher doses in people without type 2 diabetes who are overweight. What did they find? Well, actually, 50 milligrams of semaglutide, you can achieve a weight loss of 15 kilograms now. And compared to placebo, more than 20% weight loss, 20 kilograms in 34% of people. So high-dose semaglutide is now as effective as subcutaneous semaglutide. What about, so that's actually a peptide which gets broken down, which is why you need the snack. There is now a Lilly drug, which is, and I can't even say it, orforglipron. right? Which has been tested in phase 2, and that's just been published. Different doses of drugs, the maximum dose is 45 milligrams. What does it show? Well, this is again body weight of 100 kilograms to start with, not markedly overweight. What you see is that in the maximum dose, you're getting 10 kilograms weight loss, better than dulaglutide, which is 3 kilograms. And more than 15% body weight loss, about 24% of people are getting this. But what about its effect on reversing diabetes? Well, HbA1c, you can see, effectively reduced, but less than 5.7% HbA1c is now being achieved in about 30% of people. So I believe now we really are in the best of times, because we have drugs beyond single GLP-1 receptor agonists. We have the dual receptor agonists, which are GLP-1, GIP, and we also have the triple receptor, which is GLP-1, GIP, and glucagon coming through. What is the data? Well, the data is that tirzepatide, which is a dual agonist, if given to people who have pre-diabetes, who are overweight of around 100 kilograms, what happens? Well, they lose weight. And the maximum weight, you can see, tirzepatide 15 milligrams, you're now losing 22 kilograms weight. More than 25% being achieved, you can see, percentage of participants is almost a third of people. And you're curing 95% of people who had pre-diabetes. 95% no longer have pre-diabetes. They are normal HbA1c with less than 5.7%. What about tirzepatide versus semaglutide in people with type 2 diabetes? Well, this is a study that compared this. HbA1c to start with 8.3. Change in body weight, you can see tirzepatide in diabetic patients is not as effective as in people with obesity. So they achieved 12.4 kilograms in the maximum 15 milligram tirzepatide, compared to 6.2 kilograms in semaglutide. HbA1c, you can see, most significantly reduced in tirzepatide, but what about people who met glycated hemoglobin targets less than 5.7%? 46% of people no longer had diabetes. Remaining time 2 minutes, almost there. And then if you look at once weekly tirzepatide against insulin, well, actually surprising. Tirzepatide is better than insulin, titrated insulin, for lowering HbA1c. You can see that here. Tirzepatide, this bottom one, this is the insulin. And you can see weight goes up with insulin, weight comes down with tirzepatide. And HbA1c less than 5.7%, much more effective in tirzepatide, achieving about 40% of people have a HbA1c less than 5.7% compared to insulin. Surpass study is actually looking at fatty liver with tirzepatide. Again, insulin degludec, you can see weight goes up, tirzepatide weight comes down, and fatty liver, literally 20 to 40% of fat in the liver is gone with tirzepatide. The last one, triple hormone receptor agonist, retatrutide for obesity. This is the triple G. 338 adults, overweight, 108 kilograms. Here, you're achieving a weight loss of about 25%. And this is actually, the bottom panel shows you more than 30% weight loss was achieved in 25 out of 338 hours. That's 30 kilograms. The other thing is, if you're more overweight, if you have a BMI over 35, you'll lose more weight. If you have a BMI less than 35, you're going to lose less weight. And the other thing is, women do better. So women are losing more weight than men. So, bariatric surgery or bariatric medicine? Well, we know that the pouch, 17% weight loss. Sleeve gastrectomy, 21% weight loss. Bypass, 24% weight loss. The latest triple therapies, 26.5% weight loss. So my conclusions are, bariatric surgery, whether the bariatric surgeons like it or not, is going to be obsolete. A little bit like peptic ulcer surgery. Bariatric medicine is going to be a massive growth. Diabetes remission is a reality that we need to now start talking about to our patients. Thank you. And I'll finish by saying Muhammad Ali said, the man who views the world at 50 the same as he did at the age of 30 has wasted, or 20, has wasted 30 years of his life. Thank you.
First of all, Rayaz, for your elegant, illustrative, and updated talk. For anyone who's already ask a question? Yes.
Thank you very much for the elegant, informative lecture. We talk about bariatric surgery and bariatric medicine. It seems we are shifting to bariatric medicine, but this may take years. Still, bariatric surgery is a trend and followed now, widely used. And we are meeting this in our daily practice. Patients going to bariatric surgery have a dramatic weight loss, and they are expecting a lot from their diabetologist when they come back for the first visit, especially patients on insulin treatment, asking, when doctor can I shift to oral? So I have two questions. How often should we follow up our patients, our diabetic patients, who had gone to bariatric surgery after having the surgery? And when can we take the decision for those patients who was on insulin treatment to shift them to oral? Thank you.
Yeah, so bariatric surgery, actually, you know what? Honestly, I see this all the time in Qatar because we have a lot of it. Insulin, virtually you can stop, and it's not even related to the weight loss. Within a week, most of them can stop their insulin, okay? Yes, honestly, glucose levels drop after bariatric surgery markedly. Really they do, and dramatically, you know, so within a week, you see this normalization of glucose. And that's before the weight loss, and that's because bariatric surgery is creating this environment where you've got these GLP-1 levels are going up, whether you've got all these changes in metabolism, which are lowering the glucose. So you can literally stop their diabetes medication within a week. Now, in terms of follow-up, you can see at 2 years, pretty much everybody's doing okay, but when you go out long term, some of the diabetes will return. So there has to be some way of maybe having a system where on an annual basis you do a HbA1c, something like that. Just as you need to follow these people up medically anyway for vitamin deficiencies, I think. So you just do a HbA1c as you go along.
Regarding tirzepatide, I think it's still not approved. It's waiting approval by FDA. Okay.
Yeah, I mean,
the way.
Yeah, but it's available. I mean, Muhammad's gone in UAE, in Saudi Arabia. It's going to be available in Qatar in the next few months.
Use for diabetes, but for obesity?
For obesity, no, not yet. Yeah. No.
Do you prefer to use 10 milligram or 15 milligram for diabetic patients?
I use whatever works. 15, if they're big and overweight, 15 milligrams. You know, you're getting 20, 22, 24%, 24 kilograms weight loss.